Then there are imaging stage like sonography, CT scan, MRI, MRCP that helps us to diagnose as well as to stage the disease. And after staging, these helps in planning the treatment. So what we need for management of these tumor is what's the stage of the tumor, what's the extent of local involvement of adjoining structures, and what is the level of obstruction. So these things we need before planning treatment. Investigation like PET scan are helpful to have come into a metastatic involvement of like if this is there, then our treatment will be more or less a sport only. Now the biliary tract malignancy is classified to facilitate our treatment planning in type 1, 2, 3, and type 4. Type 1 lesions are that involves the common bile duct. Type 2 lesion are those involve the common hepatic duct up to the confluence. Similarly, type 3 and further divided into A and B depending upon involvement of common hepatic duct with the second order biliary radicals, whether it is only right side or left side. So we can plan treatment accordingly. Like if tumor is this one, involving the CBD mainly, we can go for excision and resection at this level and to do in a hepaticogestomy. If the same tumor is this one involving the confluence, we have to extend our resection to have in a separate anastomosis of the right as well as the left biliary system. If the tumor is like this, that involving the right side secondary order radicals, it's very difficult to anastomose these small biliary radicals. So in such cases, we can do anastomosis here, and we have to resect this part of the liver simultaneously to have a complete excision of it. So depending upon the location, the type of disease, we can plan the treatment. Similarly, if lesion is like this, we can't have any option because it is very difficult to have a biliary enteric anastomosis of so proximal small ducts, and you cannot excise both lobe of the liver. So in such cases, these are considered as inoperable tumors. So treatment, majority of the time it is surgical resection only, because this is the only modality which is associated with long-term survival. And of course, it depends on the site and extent of disease. In majority of the biliary malignancies, we need a multidisciplinary approach where surgeon, intervention radiologist, medical oncologist, radiation oncologist, physiotherapist, nursing person, and nutritional experts are there. Because surgeon can help only in 10-15% of the cases which are resectable. In the rest 90% of the cases, intervention radiologist can do by doing some endoscopy, by doing some peritoneal stenting to relieve the obstruction. Similarly, these patients are very much nutritionally compromised. So help of nursing, nutritional experts and physiotherapists is of paramount importance. So various treatment modalities for these tumors are wide excision. At times, we may need liver resection, like in case of type 3A and B tumors. And if the same is involving the distal bile duct, like in case of periampullary region, we may have to go for a Whipple resection. And if the malignancy is involving the intrahepatic biliary radicals, then we at times may need a liver transplantation if this is available. Uh, Out of these modalities, which one to be offered to whom, it depends on the stage of the disease, stage of the associated liver disease, like patient having chronic alcoholic liver disease, with intrahepatic multifocal malignancy may be candidate for transplantation, not for resection. Then some tumor factors like extent of the tumor, then vascular involvement, and then presence or absence of metastatic disease. All these are to be considered before planning the treatment. Now you see the survival of patients with the biliary tract malignancy. It depends upon the T stage, then whether nodes are positive or negative, and then your resected margin status. Overall 5 year survival is 35% provided there is complete resection only. Role of chemo and radiotherapy is very much limited, but should be considered in patients where the nodal disease is there, means excised nodes are positive or the margins are positive. Majority of the patients are candidate for palliative therapy, and in palliation, we have option of ERCP and stenting or PTC. That is, if ERCP is not feasible, like in case of hilar malignancy or Klatskin tumor, we may not be able to do the ERCP. In that case, we need a percutaneous transhepatic cholangiography followed by stenting. If these procedure of biliary diversion fails, then we have option for a surgical bypass like segment 3 bypass, segment any other segment which is free of tumor can be anastomosed with the, this intestine. Now coming to next common malignancy of biliary tract, that is of gallbladder. As already discussed, the tumor of gallbladder are more common compared to tumor of the biliary tract. So, carcinoma gallbladder again not a very common disease, having too much geographical and racial variations. And in Indian continent, particularly North Indian, are very much prone to have this carcinoma gallbladder. In our North Indian state, there is a high incidence of carcinoma gallbladder. In biliary system, biliary tract malignancy, male are affected more common than female. But in gallbladder malignancy, women are more commonly affected. And usually the tumor affects old age group. And again, unfortunate part is only 10% of these malignancy are resectable with the limited survival of 6 months. Again, etiology, not very much clear, but there is association with some diseases like gallstone disease, particularly the large cholesterol strain, they have predisposition to malignancy. And then one more entity, that is porcelain gallbladder, where there is diffuse calcification of the gallbladder wall, is also having predisposition to carcinoma gallbladder. And then chronic infection with like typhoid carriers, they have predisposition. Gallbladder polyps is also in a pre-malignant condition. But remember, majority of the polyps which are diagnosed on sonography or other investigation are polyps of cholesterol or adenomyosis. And these polyps have no malignant potential. Only the few adenomatous polyps have malignant potential, and in particular those which have size more than 1 centimeter. Pathologically, these tumors are majority of the time adenocarcinoma, or a small group of patients may have special carcinoma. These may be either nodular on microscopic examination or infiltrative. The nodular variety, which is localized, have a good prognosis compared to infiltrative type. See the spread of tumor, either a direct extension to adjoining organ, like from gallbladder to liver, or to colon to jejunum, or settling in the peritoneal cavity, or metastasis along the lymphatics. Now, if we see the clinical feature of gallbladder malignancy, in the early stage, these are asymptomatic, or the features they mimic cholecystitis, cholelithiasis, like this. And late presenting patients usually have anorexia, weight loss, palpable gallbladder mass, and jaundice. These are advanced disease. Because tumor involving complete gallbladder, then infiltrating adjoining bile ducts to lead to jaundice is a late feature rather than in an early presentation. Now, the investigation we need in the case of carcinoma gallbladder, the laboratory investigations, these are in the early stage are normal, unless until there is biliary obstruction, which is a late presentation of carcinoma gallbladder. Except for a lesion if involving in the region of cystic duct or a neck of gallbladder, they can have early biliary obstruction. Otherwise, only advanced disease presents with these obstructive symptoms. And then a tumor marker like CA19-9 is one tumor marker that is increase in hepatobiliary malignancy, and is found raised in 80% of the patient. Again, this tumor marker is not very much specific. Same can have a high titer in case of benign disease like cholecystitis, pancreatitis, or any other biliary benign disorders even can have a high CA19-9 level. Uh, Next commonest investigation, that is sonography, that can show a mass lesion in the gallbladder, or if there is biliary obstruction, then intrahepatic biliary dilatation like this, or lymphadenopathy, or in advanced disease like ascites, and this can be detected on sonography. CT scan is investigation for the lesions which are not detectable on sonography, very small lesions, or more than that, it's used for staging of the disease, involvement of adjoining vital organs like portal vein, then hepatic arteries, inferior vena cava, lymphadenopathy, metastasis like this. MRI and MRCP, we need to have our a roadmap of the biliary system, like what is the proximal extent of involvement of the bile duct. So we can plan whether we need a simultaneous liver resection, or we can continue with only bile duct excision with hepatocoagulopathy like this. Or if the lesion on a CT and sonography is not confirmatory or atypical type, then we need a MR. Otherwise, routinely not indicated. Aim of these investigation is first to get in local extent of the disease and to exclude the metastasis. One more investigation that is commonly ordered is ultrasound guided FNAC or biopsy. Remember, this should never be ordered if your patient is resectable. If the tumor is resectable, then don't go for FNAC or biopsy. Reason being, this leads to shielding of the tumor cell along the tract of this FNAC or biopsy needle, and can turn in potentially operable malignancy into inoperable case. Yes, it's indicated if your plan is non-surgical, or if the patient has disease which is advanced, or if you think your patient needs neoadjuvant chemoradiation to downstage the tumor, then it's indicated, otherwise never. Even if on all these investigation, if the tumor is resectable, definitely there is a role for laparoscopic staging before going for open exploration. Reason being, in spite of having a good resectability and operability on other imaging modality, if we do a routine laparoscopy in CA gallbladder, we will find that even 30% of the patient who were supposed to be resectable on these imaging will turn out to be non-operable because of a peritoneal or liver metastasis. The another investigation is a PET scan. Its role is mainly for detecting the metastatic disease. And one more role of PET scan may be there if you are planning a new adjuvant chemotherapy. Then you can monitor the response of chemotherapy by doing the PET scan. That whether your chemotherapy that is really is of any help to that particular patient or not. Now, the next stage, we stage the tumor, because after staging only we'll find out what the next plan we should go ahead, or what should be the outcome of that particular modality. So the commonly used staging system for gallbladder is T-zone staging. So in T lesions, depending upon whether the tumor is in situ or it's confined to lamina propria, or it's invading the muscular layer, or it's invading the serosa, or adjoining liver. So depending upon this local extent, this is further divided into T1, T2, T3, and T4 lesions. Then lymph nodes, whether regional lymph nodes are enlarged or not, or the distant lymph nodes are there. For gallbladder, like hepatoduodenal ligament lymph nodes are regional nodes. Common hepatic nodes are regional nodes. Similarly, retropancreatic, behind the head of the pancreas, these are regional nodes. Metastatic, the disease is having metastasis somewhere else in the body, then it's staged as a M1 disease. Now, once this TNM staging is done, we allocate the patient to one of the stage, like whether stage 1, 2, 3, 4A, 4B, like this, depending upon the T lesion, then involvement of the lymph node and metastasis. Now coming to treatment for carcinoma gallbladder. If the patient is having a polyp only on sonography or CT scan or any other imaging, and if the polyp is more than 1 centimeter, go for simple cholecystectomy only, either by open approach or laparoscopic, whatever one plans. If the polyp is less than 1 centimeter, then don't operate these patients, just follow up with an annual ultrasonography. If the same is increasing in size, or there is some other changes on sonography, only then consider cholecystectomy. Or even if the size is not increasing but patient is symptomatic, then there is indication for cholecystectomy for polyps which are less than 1 centimeter. In case of malignant tumors, the treatment is a radical cholecystectomy. Radical cholecystectomy means removal of gallbladder, the adjoining lobes of the adjoining segments of the liver, that is segment 4B and 5, that lies in the bed of the gallbladder, with the lymphadenectomy. Lymphadenectomy that involves the hepatoduodenal lymph nodes, retropancreatic, common hepatic, and ciliary group of lymph nodes. One more terminology that is confusing is extended cholecystectomy. Sometimes people use, but presently radical cholecystectomy and extended cholecystectomy are used as interchangeable. Otherwise, the previously defined extended cholecystectomy was means excision of gallbladder with the adjoining some other organ like part of the liver, part of a colon if it is involved. That can used to be called as extended cholecystectomy. Means gallbladder with the adjoining liver. It's extended cholecystectomy. But if you add lymph node dissection, then it becomes the radical cholecystectomy. But presently, the terminology extended cholecystectomy no more exists. Or if somebody is using, it's interchangeable with the radical cholecystectomy. Our aim of surgery is to get an R0 resection, means a complete microscopic excision. Now, once the surgery is over, we have adjuvant therapy. In adjuvant therapy, we have chemotherapy, then chemoradiation. Of course, the role is very much limited, but chemotherapeutic agents like gemcitabine has shown some promising results. And in young patient, addition of carboplatin or paclitaxel further increase the survival. Majority of the patients, we need only palliative therapy. And palliation, like chemoradiation in palliative form, or endoscopic stunting, or PTC stunting, or surgical bypass, painkillers, nutritional. Otherwise, these are only palliative treatment, which most of the patient falls in this category. Now, one more terminology used in carcinoma gallbladder is incidental carcinoma gallbladder. What is this? Means one has done cholecystectomy for benign disease like gallstones, and this gallbladder is sent for histopathological examination that revealed adenocarcinoma in the specimen. Now, what next to do? So, if the lesion is T1A, means it's involving only the mucosa and lamina propria, then no further treatment is required. But if the lesion is beyond T1A, like involving T1B, that involves the muscles, because once muscles are involved, there is access to lymphatics. So in such cases, we need completion surgery that is called radical cholecystectomy. So if some patient is coming, already has undergone cholecystectomy somewhere else, and the biopsy is T1A lesion, nothing else is required. But if it is beyond that, we need a radical cholecystectomy. Now, one more question comes in case where the cholecystectomy has been done by a laparoscopic method. In that case, there is chance that if you extract the gallbladder through one of the port, that port site may have some tumor cells. So in that case, if we know that the gallbladder has been retrieved without endobag, and through that particular port, we need excision of that port also, followed by adjuvant chemotherapy in all cases which have been operated previously. Prognosis, it's lethal disease with a poor outcome. Medium survival is only less than 6 months, and 5 years survival not more than 5%. So with this, we finish the diseases of a gallbladder and bile duct, all relevant surgically benign and malignant disease. And from the next lecture onward, we'll continue with the next organ, that is pancreas. Thank you so much.